Catherine, go ahead.
Good day, everyone. My name is Catherine Arkell. I'm an intern at the WHO World Health Organization in the Department of Reproductive Health and Research. I will be facilitating today's webinar that is jointly hosted by the World Health Organization's regional offices for Southeast Asia, SEARO, and the Western Pacific, WPRO, and the Department of Reproductive Health and Research. Ados May from Implementing Best Practices has kindly agreed to manage the logistics for this webinar. Next slide. The purpose of the webinar is as follows: to provide an overview of the WHO guideline development and the unique process of meaningful community engagement used in the 2017 WHO Consolidated Guideline on Sexual and Reproductive Health and Rights of Women Living with HIV, to present the new recommendations in this guideline, and to gain insights from national and regional stakeholders regarding implementation of the guideline. Some ground rules for the webinar. During the presentations, feel free to type any questions that you may have in the question box, which is in the control panel on the right-hand side of your screen. At the end of the presentations, I will direct your questions to a panelist. If we do not have time during the webinar to answer all of the questions, we will send responses after the call. Please note, the guideline itself has been uploaded into the handout section, which is also located in the control panel on the right-hand side of your screen. Feel free to download and share this. Next slide. So to provide an outline, we have many panelists who are experts from both regions and from the WHO. Some of our speakers will be presenting via recorded video, while others will be speaking live. However, please feel free to address questions to all panelists. I would like to briefly provide an outline of the structure of today's webinar. We will be starting with two speakers, Dr. Manjula Narasimhan and Alice Wellborn, who will provide an introduction to the guideline and some background on the unique process of meaningful community engagement used in its development. This will be followed by presentations describing the new recommendations in the guideline. These will be given via video by Avni Aman on safer disclosure of HIV, Anna Pilar-Bertran on elective cesarean sections, next slide, and Bella Ganatra on safe abortion. Anandi Yuvraj will present live the new recommendation on self-efficacy and empowerment. These will then be followed by presentations on implementation considerations. Pascal Alotti will cover best practices in health service delivery and research, Jose Belamac on policy considerations for the Philippines. Next slide. And then we will hear from Naoko Ishikawa from WPRO and Anoma Jayathilaka from SEARO on some next steps for the regions. We'll wrap up with a question and answer period. You are welcome to type your questions in the question box on the control panel on the right-hand side of your screen at any point during the webinar. They will be answered during the question and answer period. Next slide. Now, it is my pleasure to introduce our first panelist, Dr. Manjula Narasimhan. Manjula, go ahead.
Hi, good morning, everyone, or good afternoon, colleagues. In this presentation, I will provide a brief overview of the key principles behind the development of the Consolidated Guideline on SRHR of women living with HIV. This guideline was published in February 2017 and is the outcome of a broad consultative process involving national, regional, and global experts. The rationale and scope of this guideline is because in many countries, women living with HIV do not have equitable access to good quality health services and are also faced with multiple and intersecting forms of stigma and discrimination. Women living with HIV are also disproportionately vulnerable to violence and violations of their sexual and reproductive rights. This guideline starts from the point where women already know they are living with HIV, and women who are not aware of their status must first be reached by safe, voluntary, non-coercive HIV testing and counseling. In addition, although this guideline focuses on women living with HIV, it is acknowledged that the SRHR issues are in many cases similar for all women. This guideline is meant to help countries to more effectively and efficiently plan, develop, and monitor programs and services that promote gender equality, human rights, and be more acceptable and appropriate for women living with HIV. Next slide. So, just to quickly tell you that a WHO guideline is really any WHO document that contains WHO recommendations about health interventions, whether they be clinical, public health, or policy interventions. And there's a rigorous process that's followed, including for evidence retrieval, and the methodology of how these recommendations are developed is described in this GRC handbook that is shown on this slide. Next slide, please. So this guideline consciously adopts the perspectives of women, their families, and communities. It is grounded in and advocates for a strengthened, comprehensive, woman-centered approach to SRHR. A woman-centered approach is one that sees women as active participants, as well as beneficiaries of health systems that respond to their needs, their rights, and their preferences in holistic ways. It's an approach that emphasizes the promotion of gender equality as central to the achievement of SRHR. It is an approach that examines critical gender norms and supports gender equality in ways that are gender transformative to health services. It's one that requires women to be empowered through education and support to make and enact decisions in all aspects of their lives, including in relation to sexuality and to reproduction. It's an approach that calls for strategies that promote women's participation in their own healthcare. It's one that recognizes the strengths of women living with HIV as active agents in relation to SRHR and not merely passive recipients of health services. And finally, it's one that's organized around health needs and priorities of the women themselves, rather than disease management and control. Next slide, please. Unique to the development of this WHO guideline is a global community survey that was conducted by and for women living with HIV to assess their priorities and put their values and preferences at the heart of this guideline. You will hear more about this unique process of meaningful community engagement from the next speaker. To note here is that this guideline is intended to address women living with HIV in all their diversity. It also captures diversity across age groups, emphasizing that health services that promote women, the SRHR of women throughout all the stages of their life course is critical to bringing this agenda forward from adolescence to the postmenopausal years. Next slide, please. This framework therefore shows the key principles at the center of this document. And in addition, you see in blue the health interventions and in purple the enabling environment. Both are important because it is recognized that while policies and programs and interventions to improve SRHR of women living with HIV do exist in some places, these alone will not bring about improved health outcomes in the absence of a safe and supportive enabling environment. This consolidated guideline brings together new recommendations, but also existing recommendations and good practice statements into one document. The following 3 slides show a summary of the key topics that were identified for this guideline. The next slide, please. This slide highlights the key recommendations that are within this guideline, and we acknowledge that there may be others that we need to bring in or new research that needs to be highlighted, which will be brought in at later updates of this guidelines. Next slide, please. This slide highlights the good practice statements that have been brought in, again, for the creating and the enabling environment and for the health interventions. Next slide, please. So this framework developed for this guideline therefore supports recommendations and good practice statements that can reduce the sometimes significant barriers women living with HIV face to accessing and utilizing high-quality services. We recognize that there are many excellent initiatives and programs and policies that already exist in the countries and in the region. And in implementing these global recommendations and good practice statements, the regions and countries can adapt them to the local context. Next slide, please. In conclusion, therefore, an integrated approach to health and human rights and gender equality lies at the heart of ensuring the dignity and well-being of women living with HIV. Action on the recommendations in this guideline therefore requires a strategy that is not only informed by evidence and appropriate to the local context, but is also responsive to the needs and rights of the women living with HIV. I really look forward to receiving the feedback on how best to implement this guideline in your country and region, so that we can overcome barriers to service uptake, use, and continued engagement, reduce stigma and violence, and deliver the highest quality of care. Thank you.
Thank you. So, greetings everybody. I've called this part of the webinar with my slides the power of positive participatory processes, because that's really what it's about, how powerful a participatory process can be. And this was very much a community-wide engagement, and you can see all of those wonderful different logos there as an example of this. So this was a values and preferences survey which fed into the new guideline and which informed the guideline in relation to many different issues faced by women living with HIV in all of our diversity from around the world. So there was a real sense of intentioned community engagement from the outset. So we had a core team leading the process, and two of us are women living with HIV, Mary Jo Vasquez and myself. And then we also invited wonderful women from around the world who in many ways are also really great activists and who have many different diversities in terms of how we have acquired HIV, whether maybe we've grown up with it, whether we've acquired it through drug use, whether we also identify as sex workers or lesbians or bisexual women, whether we are immigrants or whether we are indigenous communities, and whether we're transgender women. So there were a lot of different diversities represented in this global reference group. So the Global Values and Preferences Survey itself was created and led and informed by this global reference group. So as we shaped the questions which we had in the survey, they were questions which came from the global reference group members and were shaped by them, highlighting key issues which affect all of us in our lives in different ways from around the world. It was the largest survey ever of women living with HIV. In the end, we had 832 online respondents on our SurveyMonkey website, and we also had another 113 who took part in focus group discussions. We had 7 different languages and more with the focus group discussions, and the respondents were also from a diverse range of backgrounds and experiences, all of them women living with HIV, aged between 15 and 72. In terms of the methodology, we adopted what we call an appreciative inquiry approach, which is a positive approach building on women's agency and resilience and courage to cope with the many different issues that they face in life. And it was also a life course approach, looking at the whole range of experiences across a lifetime. It was grounded in human rights. It produced both quantitative and qualitative results. As I said, the survey was both online, and also we had focus group discussions in some countries to make sure that some women who don't have online survey access could take part. And it really identified and expanded upon those key priorities identified by the global reference group members initially. So what findings did we have? Well, we created this beautiful house image out of the many and complex different findings that we produced. And as you can see, there are fundamental foundation stones, most of all at the very base: safety in healthcare, at home, in the community. There are those wall pillars, those panels: human rights, gender equality, social justice, our meaningful involvement in everything which affects our lives, and protective laws. Then we have those different parts of the roof: our sex life, our pregnancy and fertility, treatment and side effects, and so on. And then we also have these three beautiful birds taking off at the top. And the idea of this was to say that if you achieve our sexual and reproductive health and rights, then not only will we benefit, but also our partners, our children, and our community will benefit. And this was a key message which we really wanted to get across, that first and foremost, if we're able to achieve our sexual and reproductive rights, then everything else will follow. And that the idea of this house was to present a safe haven for women living with HIV in all of our diversities around the world. We achieved this. The women who filled the form in said how much they had enjoyed and appreciated doing the survey, and we really feel that this is the way forward, and that how so many other surveys and guidelines could be developed in future. Thank you.
My name is Apni Amin, and I'm a Technical Officer for Violence Against Women in the Department of Reproductive Health and Research. I will be talking about addressing violence experienced by women living with HIV and the WHO recommendations for this. Why should HIV services address violence experienced by women living with HIV? Data published by WHO in 2013 show that women who experience intimate partner violence are 1.5 times more likely to acquire HIV in some regions of the world. Survey conducted of women living with HIV and their values and preferences for the production of these guidelines for women living with HIV show that 89% have experienced some form of violence. Systematic and other literature reviews on HIV disclosure show that experience of fear of violence is a barrier to HIV disclosure and to accessing treatment and care services by women. Politically, in May 2016, the 193 member states of the World Health Assembly adopted a global plan of action on health systems' response to addressing violence against women and girls, and in the global plan of action identified sexual and reproductive health and HIV services as key entry points for integrating actions to address violence against women. In the Consolidated Guideline on Sexual and Reproductive Health and Rights of Women Living with HIV, there are 2 new recommendations for addressing violence against women living with HIV. The first is aimed at policymakers and service providers and raising their awareness that many women living with HIV who are considering HIV disclosure either fear or are experiencing or at risk of intimate partner violence. The second recommendation goes beyond raising awareness on actions to be taken by service providers, and this includes discussions about the challenges of their situation, potential risk of violence, and actions to disclose HIV status more safely, and also to facilitate links to available violence prevention and care services for those women who disclose that they are living in a situation of violence. So those guidelines build on previously issued guidelines by WHO in 2013, which were aimed at healthcare providers to respond to intimate partner violence and sexual violence. And so the 2013 guidelines include 5 recommendations for healthcare providers. The first is on asking about intimate partner violence. And the WHO recommendations are to use a clinical inquiry approach, which is based on signs and symptoms, and asking women when they see these signs and symptoms, rather than universal screening. So WHO does not recommend universal screening. The second recommendation is for offering first-line support to those women who disclose intimate partner or sexual violence. And the first-line support are adaptation of the psychological first aid, which has several steps including listening empathetically, offering non-judgmental response, addressing the woman's practical needs, and linking her to different social support services. The third recommendation is to train healthcare providers at both pre- and in-service level in how to ask and to offer first-line support. The fourth recommendation is to integrate care for women experiencing violence into existing services rather than having standalone services for violence against women. And the fifth recommendation is that mandatory reporting of intimate partner violence to the police is not recommended. To help operationalize these guidelines and recommendations, in 2014, WHO published a clinical handbook called Healthcare for Women Subjected to Intimate Partner Violence or Sexual Violence. This clinical handbook has a number of job aids and tools with practical instructions on how to implement the recommendations. One of those tools is around implementing first-line support, which we call LIVES. And LIVES has basically 5 steps. Listen to the woman empathetically. Inquire about her needs and concerns, including physical, social, and practical needs. Validate by showing and assuring her that she's not to blame. Discussing a plan for her safety, which is the enhanced safety component. And the fifth is to facilitate social support by connecting her to information and other services. Forthcoming in 2017 and 2018 are 2 addendums that we will make to the clinical handbook. The first is for family planning providers to support women experiencing violence with safety in choosing contraceptive methods, and the second addendum is for HIV providers to support women experiencing violence with safety in relation to HIV disclosure, which will help operationalize the recommendations contained in the new consolidated guidelines for women living with HIV. In addition, we will also be publishing a manual for health systems managers on how to design, plan, and monitor and evaluate services for violence, and a training curricula for both pre- and in-service level for healthcare providers on violence against women. Thank you.
Hello. This presentation will briefly explain and contextualize the recommendation on mode of delivery. An elective cesarean section is a cesarean section that occurs before the onset of labor and before rupture of membranes. Elective cesarean section has been recommended as a mode of delivery for women living with HIV infection in order to minimize HIV transmission to the newborn. However, the past decade has seen important shifts in HIV clinical practice and management. As the underlying risk of perinatal transmission during delivery is associated with disease stage and antiretroviral use, evidence in the past may not be relevant in current practice. For this reason, WHO has conducted a systematic review and meta-analysis to assess maternal and perinatal outcomes, comparing elective cesarean section with other modes of delivery in women living with HIV, but also according to type of therapy, viral load, and CD4 counts. This systematic review provides the updated evidence for the new recommendation in the guideline. Elective cesarean section should not be routinely recommended to women living with HIV. In 2015, WHO released a statement on cesarean section rates, which emphasizes that cesarean section should be undertaken only when medically necessary. And rather than striving to achieve a specific rate, efforts should focus on providing cesarean section to all women in need. As with any surgery, a cesarean section poses risk for women, particularly in settings that lack the facilities or the capacity to conduct safe surgery or to treat surgical complications properly, or where access to labor care or repeat cesarean section in subsequent pregnancies cannot be taken for granted. Because risk and benefits differ across settings, and for individual women, depending on the underlying risk of complications from a surgery such as cesarean section, and the underlying risk of vertical transmission of HIV during delivery, the evidence suggests that routine elective cesarean section for all women living with HIV without further considerations may not be appropriate. The decision to undertake a cesarean section should emerge from careful and personalized consideration of all the factors playing a role. How to translate this recommendation into practice at point of care, and how to discuss with each woman and address each woman's need may present numerous challenges for both healthcare providers and women. Tools need to be developed for this purpose. The WHO Department of Reproductive Health and Research is committed to developing tools to support implementation of this new recommendation. It is important that these tools are practical and reflect the needs of the end users. Potential tools being considered are infographics to support healthcare providers, but also for women living with HIV, so that they have the information necessary to make an informed decision. Thank you very much.
The elimination of unsafe abortion is one of the key elements of the reproductive health strategy that was endorsed by the World Health Assembly in 2004. Components of eliminating unsafe abortion include comprehensive sexuality education, access to contraception to prevent unintended pregnancies, safe abortion care when unintended pregnancies do occur, and the treatment of complications when abortions happen unsafely. Women living with HIV have the same needs for all of these services as do other women. This guideline explores the questions of clinical care for women living with HIV. In particular, it looks at the question of whether surgical and medical abortion are both effective and safe options for women living with HIV. Medical abortion is the use of drugs, mifepristone and misoprostol, in order to terminate a pregnancy, and surgical abortion refers to the use of transcervical procedures like manual vacuum aspiration in the first trimester and dilatation and evacuation at later stages of pregnancy. The WHO's Safe Abortion Guidelines recommends that both of these methods are safe and effective options, and women should preferably have a choice of both of these methods. Does this recommendation hold equally true for women living with HIV? Are there any particular concerns related to bleeding, related to the vomiting induced by medical abortion drugs that might be different for women living with HIV? These are the questions that this guideline in particular explored. The systematic review did not identify studies that directly compared outcomes of abortion in women living with HIV with other women. However, no concerns or adverse side effects were reported in women living with HIV, and issues related to bleeding and vomiting with drugs are relatively minor side effects of the abortion procedure. Hence, the guideline makes the recommendation that women living with HIV should be offered the same options for both surgical and medical abortion as all women. If only one of the options is available, women living with HIV who desire voluntary abortion should receive the available option. Women living with HIV should not be coerced into terminating their pregnancies as a result of their HIV status, or be coerced into accepting long-term contraception post-abortion if they do not wish it. But it is equally important that women living with HIV, when in need of safe abortion care, should receive this. It is important to create an enabling regulatory environment and to ensure that additional barriers are not faced by women living with HIV. Thus, safe abortion care and post-abortion care must be an integral part of all comprehensive reproductive health services for women living with HIV. More specific information on the provision of safe abortion care services can be found at all of these resources, which are available for download at the HRP website.
Good afternoon, everybody. WHO recommends that for women living with HIV, interventions on self-efficacy and empowerment around sexual and reproductive health and rights should be provided to maximize their health and fulfill their rights. What do we mean by self-efficacy? It is clearly defined as an individual's belief or her capacity to execute or take affirmative actions and demand services. And empowerment is defined as the process of increasing the capacity of individuals or groups to make informed choices so that they can realize their sexual and reproductive health rights. And so one of the key aspects that I would like to highlight here is my own involvement in the process of the guidelines development as part of the guideline development group. As a member, I enhanced my own understanding how guidelines have been developed and what is important, how women living with HIV, and particularly the survey that Alice presented has influenced the guidelines development process, and the recommendations have been formulated. To me, that itself is a great empowerment process leading to a new revised guidelines for women living with HIV. It's very critical that women living with HIV's capacity needs to be increased, and we need to invest resources in making sure that they have access to these interventions. What is also equally important, yes, when we empower women living with HIV and increase their capacity, what does it mean? So they have the potential and they have a capacity that stays with them as a reserve, which they can tap into when there is a need arise, which is very important. So we cannot leave them just on their own and not to have access to these services. So it's very critical. Equally, when we demand, so what does that happen? It means in reality. So we actually increase the demand side, and what does it mean? Like when the women go out and looking for services and seeking services, when the supply side is not ready to provide services. For example, in healthcare settings, if the healthcare providers are not aware of or knowledgeable on sexual and reproductive health rights of women living with HIV, it is going to be a disaster because they will not be able to really meet the needs and they will not be sensitized to the issues. So it's equally important and critical to really make sure that healthcare providers' knowledge on sexual and reproductive health rights of women living with HIV, women in general, need to be actually increased. And we also found out that, through our own study in ICMR, research on sexual and reproductive health rights, identified the gaps in this area around the healthcare providers, so which actually validating this recommendation. So it's very important that when we actually improve both sides, demand and supply side, then the sexual and reproductive health rights of women living with HIV can be realized. In order to really it's just not enough to have very few training programs or interventions to empower women living with HIV. We really need to have continued support and interventions and package of services in place so that women living with HIV can access these services and realize their SRHR needs. In order to realize the SRHR rights, which includes matters related to sexuality, family planning, antenatal care, and also avoiding STIs and unsafe abortions, this social capital needs to be built, which they can tap into whenever there is a need. So it's very important to create an enabling environment in terms of the laws and policies and programs and projects and interventions. And global values and surveys has already actually highlighted the fact that how important it is to address the financial needs or insecurity of women living with HIV. And many countries have come out with government schemes like both the conditional cash transfers and other schemes to facilitate women's access to services. So it's very important for women to have these enabling environment so that they actually facilitate easy access and promote the sexual and reproductive rights of women living with HIV. I would briefly touch upon the brief sexuality communication recommendation, which is already an existing recommendation, but it's very critical because it's also again contextual and based on where it can be introduced and who is going to be providing these services. Integrating HIV into existing health services is increasingly being recognized by governments and program managers at national level, particularly in developing countries. So I can talk about the consultative epidemic setting where I come from. It's very important really to integrate this sexuality communication messages into the HIV testing and treatment and counseling. So psychosexual counseling is very critical for promoting sexual well-being. And also social security, promoting social security and access to various schemes so that women can have access to more comprehensive services. And women in all diversities and their needs are different. Women are not a homogeneous groups. So we are sex workers who are living with HIV, we are IDUs who are living with HIV. So we are young women living with HIV. So we are older women living with HIV. So we have different needs. So it's very important that our understanding about our own issues is very critical. I stop. Thank you.
Hello, everyone. My name is Pascal Alate. I'm currently Professor of Public Health at the Monash University campus in Malaysia, and will soon be taking on a new challenge as Director of the UN Institute for Global Health. I'm also the co-chair of the Gender and Rights Advisory Panel for HRP, and therefore had the privilege of being a part of this amazing process in the development of these guidelines, and I'm really pleased to be able to contribute to this dissemination process. Next slide, please. I will restrict my comments to what I think remains a somewhat neglected part of the guidelines development process, that which relates to the context in which these guidelines will be used. Implementation may require revision of existing policy or introduction of new policies. These have to fit into health systems that have a myriad of priority issues. And integral to this implementation process has to be monitoring of best practice to ensure that the evidence is being used, and monitoring of the health outcomes as a critical part of the implementation process to ascertain the ongoing relevance and veracity of the guidelines. I refer you to the points listed in the slide. In this, therefore, we enter the realm of the social, political, cultural, and economic contexts, which vary significantly by region, by country, and even across districts and within clinical settings. In preparing for this webinar, I sent the guidelines to a number of colleagues and professional women living with HIV within the region who had recently accessed public or private healthcare services for sexual and reproductive health reasons. I asked them to comment on whether the guidelines reflected their experience and what they thought would be required at a systems level to support the implementation. As was expected, for the most part, the issues were similar. The centralization of HIV services, often in infectious disease units, made it difficult for treatment to be offered to the person as a whole. The services were geared towards treating the disease or the specific health complaint. Infectious diseases doctors had little knowledge of family planning options, for instance. Conflicting advice was given across obstetricians, pediatricians, and infectious disease specialists. And there was no expectation that care could be provided in multidisciplinary teams, and this was particularly pertinent in the private healthcare sector. In a region where governments are investing in medical tourism, there is a growing focus on fine grading clinical specializations, so practitioners know a lot about a little, and next to nothing about the range of issues relevant to a woman who presents with requirements across multiple disciplines. On the flip side, so not looking at the private sector, is the provision of sexual and reproductive health services in geographically remote locations and to much poorer communities where decisions for clinical care necessarily default to life and death decisions, and where cultural values are so heavily entrenched that the practitioner could be putting themselves at risk in trying to implement some of these guidelines. Now, that's not to say that these are insurmountable challenges, but what it does highlight quite starkly, I think, is that the implementation of these guidelines cannot be done effectively without serious consideration of the broader health system and cultural context into which guidelines are being implemented. As we plan the steps for implementation and monitoring, we need to clearly understand how the system-wide structures enable or inhibit these critical functions that ensure the realization of women's rights. Next slide, please. So in keeping with the broader methodology for the development of these consolidated guidelines, it's worth noting that there are a number of grassroots rights-based women's organizations that have developed innovative ways of working within existing systems, recognizing all of these contextual concepts. It would therefore be a missed opportunity if these organizations were not involved as critical stakeholders in the implementation process. And this is a process that is often, this is a part of the equation that is often not looked at. This would mean building up their capacity as well as a part of the system through knowledge transfer, so that they are able to support and advocate on behalf of women living with HIV, as well as, in some cases, on behalf of practitioners. Many of these issues underpin the broader equity agenda started through the MDGs and are absolutely central to the SDGs going forward. Therefore, the role of the regional and country offices of the WHO and other related agencies cannot be overemphasized, but it may require new ways of working. And as a researcher, of course, with strong interest in the evidence for implementation, I have to end this with what I think are some of the major research questions that are a part of the implementation agenda. Thank you.
Hello, everyone. Our next speaker is to be Dr. Belamak, but I believe there have been some connection issues on our line here. So we would be moving next to Naoko, who I believe also may be having connection issues. Therefore, I suggest that we move to our last speaker, Anoma, Dr. Jaya Thilaka, and if we are able to connect our two other speakers, which I hope we are, then we can loop back to them and include them.
Hello, I am Dr. Anoma Jaya Thilaka, speaking from WHO Regional Office, Southeast Asia region, and then I think it's a very wonderful webinar that it's really highlighted most of the important issues in women who are living with HIV in the sexual reproductive health. So then my part is how we are going to take forward these actions in the region. As Professor Fiscal-Alati mentioned, it's about its real difficult part is that how to disseminate these things, and not only dissemination, how to include it in the our programs. So it's really in as a regional office and in the country office, 11 country offices. Hello? Hello?
Go ahead. We can hear you. Go ahead.
Okay. And the 11 country offices in our region that what we supposed is dissemination is most important. I think we already have disseminated with WHO country focal point and the ministry focal point in both HIV and MRH, maternal and reproductive health. So this is a joint effort because it's women living with HIV, it's mainly sexual reproductive health, and then our both department of HIV and the MRH has to be worked together in this particular area. So then we already have done the dissemination, and then also that other important thing is that we are in the process of developing updating the MRH, maternal and reproductive health strategic guidance for the countries, in line with Global Strategy for Women, Children and Adolescent Health. So then this is a good opportunity, so we can incorporate these sections into that our strategic guidance document. Another thing is we recently conducted the family planning updated meeting in the regional meeting. So the family planning area, we have already discussed with all the focal point in the WHO country office as well as in the country focal point. Then we are now in the process of updating the national guidelines on family planning. So this is a good opportunity, so we can include this section in the family planning guidelines. And other thing is as same way that even in the it's a joint activity in the HIV/AIDS and the GBV. Gender-based violence is a different programs areas in the most of the country offices. So they also must try to incorporate all these things. We already discussed with the HIV and the GBVs in our department. So to be incorporate these things into their national, their strategic regional guidance as well as the national guidance. But the important thing I want to highlight, so actually when the financial resources and things comes, because the MRH section doesn't have much of voluntary contribution or other funding opportunities. So that the HIV is most of the time is having other resources. So then when the budgeting and planning also we must consider together and incorporating this into the HIV plans as well as the MRH section. So that's what I think we are planning at the moment. I hope this is a very comprehensive guideline. It's quite user-friendly, and its most important thing is that it contains all the existing recommendations and the good practices as well as the new one in one document. So it's quite, I think it's quite user-friendly to be disseminated and then to even for the country to be understand about it. Thank you.
Thank you, Anoma. I think that we have Naoko connected now. And so Naoko, would you like to go ahead and talk about next steps for your region?
Naoko, can you hear us?
So it seems that we're still having some technical issues here.
Hello. Okay.
Great, go ahead, Naoko.
Okay, actually I'm with Dr. Very Mark, so maybe he can go ahead.
Yeah, that would be great if Dr. Belamak can start. The only thing is your audio is quite distorted, so if you can mute anything else that's going on before you speak, that would be great. Thank you. Go ahead, Naoko. Apologies, everyone, for these technical issues. Dr. Belamak and Naoko, if you are able to speak, go ahead. We'll wait a few more minutes to see if we can get you connected in, because we would love to hear what you have to say.
While we're waiting for Naoko and Dr. Belamak to connect, if there are any questions, there they are. Okay.
Hello?
We can hear you. Go ahead.
Hi, this is Gerard. Can you hear me now?
Yes, hello Gerard, go ahead.
Hi. I'm Gerard. I'm a medical officer in the Philippines. I am in charge of the HIV and viral hepatitis program here in the country, and my interest is on the providing comments on statements on cesarean section among people living with HIV. As you see in Philippines, we have a lower number of HIV cases among pregnant women compared to our other key populations. This is primarily because of the considered relatively weaker screening program among our pregnant women. However, my comment will not revolve on the weak screening program because at the program level, our issue is more on the linkage to care of the pregnant women living with HIV. The main issue of linkage to care is when they reach the health services, our specialists, our obstetricians in the country would require our pregnant women with HIV a baseline viral load. And you see, baseline viral load is quite a challenge here in our country because it's only available at the national level, not at the grassroots or at the periphery level. So we welcome the document that would recommend that cesarean section would really be discussed thoroughly among the pregnant women. My identified challenge in implementation of this section, specific session in the consolidated guidelines, is the engagement of our private sector, private service providers, especially our medical specialists, our obstetricians. As late 2016, the Department of Health already started doing consultation meeting with our obstetricians. However, it seemed we had a difficulty and a bottleneck in really adapting the guidelines because our private physicians would have different guidelines to follow, and they would insist that viral load will be part of the baseline test among our pregnant women. Although I acknowledge that this issue is a local issue that has to be resolved by in country, but what would I suggest is for WHO to take lead in higher level advocacy in international bodies that would influence the private sector also in our country, or at least the WHO would help us identify and provide a capability building with the key opinion leaders in our private sector. I'm really highlighting the role of the private sector in Philippines because it is estimated that 40 to 60% of the deliveries of pregnant women in general in our country are being done by the private sector, so much so that they will have big impact. They could be an obstacle, however, they could also be a big opportunity in helping us implement the consolidated guidelines. So I would like to end my comment by emphasizing again that it is really very important that the private sector, especially the clinicians, the obstetricians, are involved at the highest level of advocacy in the implementation of these guidelines. Thank you very much.
Thank you so much, Dr. Bellamack. Naoko, did you want to add to that for the WPRO region in general?
Yeah, maybe I can add just very short comment from the regions. And first of all, I think we are very happy to see these consolidated guidelines for women living with HIV. And we know that perhaps most of the recommendations are existing and they are already in policies or already in implementations in many of our countries in the regions. But at the same time, there are a few new recommendations, including the C-sections and also for disclosures, safe abortions, and which I think it is really timely for our regions, and because many countries are now revisiting their own national guidelines for including treatment and then sometimes for the testings and also preventions of HIV. So we are hoping that will be incorporated to their new national guidelines. And the one issue here in our region is that really we are having a very concentrated epidemic, and most of our new infections are coming from key populations, men who have sex with men and people who injecting drugs and sex workers. So here in our region, we have a little bit specific challenge for women living with HIV, and being there also from key populations, they have another challenge of the facing or the accessing the services which they need to receive due to their very stigmatized or the discriminated status of being key populations. So that they are having the double challenges by being the women, which is already vulnerable, and then also for the key population status. So we really need to address this issue from the regional perspective. But unfortunately, since this is very key population focused epidemic, and often the women living with HIV is not really visible in the policy formulation levels at the national levels or also at the implementation status. And we see a lot of the discussion among MSM or the people who inject drugs who are mostly males, but not really from the women living with HIV in the region. So we are hoping that this new guidelines or new recommendation could provide us the opportunity to reinforce or raise the awareness of the needs of the women living with HIV and together with the country. So we are hoping to work with country to consider and implement these new recommendations in the Western Pacific regions. Thank you very much.
Perfect. Thank you so much, Naoko. Thank you to all of the panelists for their excellent presentations and comments. We're now going to move to the question and answer. So please type your questions in the question panel on the right-hand side of your screen. The first question that we're going to start with is directed towards Manjula. And the question relates to whether the survey was done in place of a systematic review.
Right, sorry. So no, the survey was done really to first understand the needs and priorities of women living with HIV. Often the engagement of the community or the end user of a guideline is brought in during the process or towards the end of the process. So if there's a guideline development group or an expert panel that's convened, it's normally at that stage, or sometimes communities are not engaged at all in guideline development. And what I felt was really important in this situation is that we really needed to hear from the women living with HIV, and also not only get in the buy-in, but their ownership of this document, because it ultimately affects their lives. So the survey was done, and outcomes of it influence the outcome of the recommendations and the guidance, but did not replace the way the evidence retrieval was done. The main topics for the new recommendations was done in the normal rigorous process that we follow for guideline development through recommendations from the systematic review and the guideline development group. The key topics were identified in that manner, and systematic reviews were done for each and every one of the new recommendations and the best practice statements that are highlighted. Thank you.
Thank you very much, Manjula, for that. I believe Anandi wanted to just add something a little bit further. Anandi, did you want to say something? And please, panelists, remember to unmute yourselves before you speak or answer a question.
Yes, thanks, Catherine. Yeah, so in terms of the, I just want to quickly reflect and, on the process itself. I know, I think the guidelines have, compiled all the recommendations, the existing guidelines, recommendations, as well as the new guidelines based on the evidence. And as Manjula pointed out, if you really skim through the guidelines, and mainly the pages 12 to 16 or 17, so that the first few pages on, it has the listed out all the recommendations. You can see many of these guideline recommendations. You can see on the right side, strong recommendation, low quality evidence, from low to, moderate to very low to low, and indirect evidence. So, but it does, what does it mean, like, for women living with HIV? We know that, issues of women living with HIV have been marginalized. It's been, never been given an opportunity to talk, or, don't have enough programs, interventions to collect data. So we are operating in that kind of a platform. And so it is very important really to understand that, so there is lack of evidence or low evidence does not mean that we women living with HIV do not have needs or issues which are pertaining to, sexual, health and family planning needs, and especially particularly in the, with the ARV and women living with HIV are forthcoming to really to, make decisions regarding their family planning. So it's very important that the field has changed, the landscape has changed. So it's very important that, we need to continue to actually build on the evidence. And so which means then we need to really have programs. So where does the evidence come from? Without programs and implementing the projects and focusing on women living with HIV and integrating women living with HIV issues into the healthcare system and broader health programs, we will not get any data or evidence to enrich or to improve our guidelines. So to me, I think it's a beginning and it's just not the end. And so we need to continue to develop on this and continue to build on the evidence. That's coming to the evidence. And I just have few comments and kind of reflecting on some of the new recommendations, particularly the safe disclosure, which and then with and how healthcare providers need to be considering the voluntary HIV disclosure, and they need to recognize the fear or expressed or perceived fears of women living with HIV, and then the risk of intimate partner relationship, partner violence. I just want to flag this issue here that India just recently, actually in both Sabhas, Rajya Sabha and in Lok Sabha, we have passed the bill, and the HIV bill, the Act 2017 is in place, and so rules are being developed now by National AIDS Control Organization. It speaks exactly to these guidelines, particularly, it says one of the recommendation or one of the clause in the bill says assess potential consequences of gender-based violence to be met out by disclosing HIV status to partners. And it also, uphold that safety of women outweigh need for disclosure to partners. And this is according to the Act. So you can see how the, India Act, the HIV bill, actually directly speak to this guidelines. And we already have an Act that actually stipulates that. And in terms of the C-section, I just want to say quickly on that comment on elective cesarean. And many developing countries, especially India, where private healthcare providers insist that positive women go for C-section, and it's also a conditional, that if you don't go for a C-section, then we will not provide services. So it's kind of women are actually coerced to kind of go for C-section, even though we know there evidence for both negative and positive women. There is no need for C-section or routinely no need to be offered, but it is a norm in many settings. So we don't have any regulations, so that's something we really need to really think about. And in terms of the safe abortion, I think we know when we talk about this safe abortion, recommendation, there is emerging unmet family planning needs. It's very quite high, and particularly developing countries. And the instances we also know from India, where the Supreme Court also denied women living with HIV requesting for abortion she sought legal redressal to terminate her pregnancy in 24, 25, 6 weeks, but then it was denied. And so these are some of the challenges we are facing. So how actually the health system can actually empower the judiciary as well on these issues. It's very important. And I just want to highlight when one global law or statutory from USAID protecting life in global health assistance, which is actually or other abortion related restrictions apply to all USAID fundings. So I request all the partners who are in this panel and also the implementing partners that foreign NGOs have to agree as a condition of receiving global health assistance that they will not perform any or promote abortion as part of the family planning. So there are implications for millions of women whose unmet needs are like a safe abortion is part of the family planning. So we really need to really address and how we can actually look at these.
Thank you.
Thanks.
Thank you, Anandi, for those really great points. I just want to get to some of these questions as well. So thank you very much for your extra comments there. I'm just going to move on to the next question, which is a really good one, I think. The question is, how does the guideline address issues related to gender non-conforming individuals? And are there any specific approaches different than for gender-conforming women? I'm going to address this out to the panel. I think perhaps let's start with Alice and see if she has any comments on this. Alice, would you like to speak to this? Just a reminder that if you are going to speak to unmute yourself, but Mandela, did you want to speak to this question at all?
Actually, sorry, this was Alice here. I thought that I had unmuted, but I haven't, sorry. I just wanted to say it was a really important and good question, and there's so much more that needs to be done to understand issues facing gender non-conforming women. What we did ensure in the global reference group was that we included a transgender woman, Cecilia Chung, and we wanted to make sure that we had somebody who could speak to and relate to some of these issues, and therefore it was really important to us to include somebody who has some personal experience of the issues faced by gender non-conforming women in the group, and we certainly had responses from gender non-conforming women to the survey. However, I think it's a really important area that needs far more future research, and I just hope that these guidelines are the first step in opening this up. And in fact, what's happened since is that Cecilia, together with colleagues around the world, have developed their own survey amongst themselves using a similar approach to the approach taken here with the Values and Preferences survey, and have also developed their own network, building again on this research as a platform. So whilst these guidelines don't themselves go nearly far enough, at least there are beginning to be other doors opening to develop research and understanding by women who identify as gender non-conforming, and reaching out to understand more about what needs to be done around policy, guidelines and implementation. Angela.
Hi, thanks very much, Alice. I absolutely agree that there was, we did try and include diversity of women living with HIV in this guideline, but as Alice just said, it's a first step. There are many doors that need to open, and much more that we would need to be addressed in perhaps later updates of this guidance. And certainly we did see that there's a real need for more research and bringing in the knowledge and research that we call in sort of gray literature into guidance development process in a way that that we can build upon the knowledge that is out there. But certainly doors have been opened not only through the survey, but with the guideline development itself, and hopefully many more will, and we can continue to work towards a better understanding of some of these issues. Thank you.
Excellent. So the next few questions I'm going to combine into sort of a general question. There are several questions with respect to the C-section guideline from Indonesia and the Philippines that were identified, ministers of health or members of Ministries of Health. And the questions vary a little bit, but effectively the questions are, can you clarify this? Is a C-section recommended for a woman living with HIV? And please elaborate on this. So we do actually have Ana Pilar, who did the video discussing this guideline on the call as well. So I'll pass it to her to perhaps elaborate a little bit on C-section in the context of an HIV positive woman.
Hello, good morning. Ana Pilar Beltran here. Regarding cesarean section, as we explained in the video, the latest systematic review was back to the early 2000s, and actually the evidence that because of the changes that have evolved and have happened over the last decade, actually what was the best evidence there may not apply now, and in fact it doesn't apply. And that's why the World Health Organization conducted this new systematic review that has fed the guideline, and that has concluded that routinely we shouldn't just take for granted that the best option for any women living with HIV in terms of mode of delivery is cesarean section. Because as the video says, the risk and benefits are going to vary according to the region, according to the setting, across women, and then decision needs to be made in consideration of all the different aspects that come into play in a specific region, in a specific setting, and with a specific women. And it may turn out that yes, a cesarean section, an elective cesarean section, may be the best option for specific women, but that shouldn't be taken for granted, and it should be always, the decision should always come out of a discussion of the factors that surround that woman, that setting, and those circumstances.
Perfect. Thank you so much, Ana Pilar, for that. I think we have time for probably one or two more questions. So the next question is in relationship to, it's in the context of India, this question was asked, and this individual wanted to know what the WHO can do to help governments change laws with relationship to same-sex relationships, IV drug users, and female sex workers as a very vulnerable group who are afraid to seek health services in India. I'm wondering if, Anoma, if you would like to speak to this at all.
Hello.
We can hear you. Go ahead.
No, I think I'm not strong enough to answer this question. I think I have to discuss with my HIV colleague, Dr. Rewari. I don't know whether he is already connected or not, because this is an important area. I think the HIV section has to be managed because it's not my area of work. I'm sorry.
No, that's very fair. Do any other panelists want to speak to this, Manjula?
I think Dr. Rewari had some connective problems. He just sent me an email that he wasn't able to connect. I mean, for the context in India, Anandi, do you want to say something related to this?
Sure.
It may be best that we can also
yes.
respond by email and ask the regional office to respond by email after the call.
No, if I may understand the question, you know, women who are in all diversity, like have their access within the program. Am I right? Catherine, is that because
yes. There was
okay.
a question specifically for sort of non-maternal health and other vulnerable populations.
Yeah, other vulnerable populations. So it's very important that there, we have targeted interventions, and we are just reformulating our national strategic plan, at national level, and we were kind of looked at really providing a comprehensive service and packages. Just not only HIV related services and also gender-based violence, and we looked at social strengthening the referral system, and particularly if I just may take this one subpopulation, which is MSM, who are, we know that India and many other Southeast Asian countries, and they so many of them are married already and they have spouses, and so their access to sexual and reproductive health is very important. So how how the targeted intervention can actually address those needs of their spouses and their family planning needs, and because the MSMs like me want to be in that relationship, and as because of social pressure, it's because of various other reasons, which actually we need to respect that, and then we need to see how we can actually update there, because it's because MSM, they don't need any of these understanding, or but it's very, in reality it's different. So we really need to see how we can actually imbibe all these learnings and evidences and recommendations and guidelines, so that they also understand how they can seek services and for themselves and for their spouses. So, and again, transgender community, we have a transgender bill which is actually going to be tabled very soon. So we are kind of looking at what are the opportunities that transgender community can have access to, in various sectors and line ministries, and they have access to this HIV prevention services. So those are some of the aspects that we are looking at.
Excellent. Thank you so much for that, Anandi. In the last few minutes that we have here, I just wanted to see if any of the panelists had any final thoughts that they would like to contribute.
Catherine, I just wanted to add one more thing to Anandi's comments just then, is that in terms of issues related to key populations, the HIV department of WHO, there are guidelines specifically on treatment and care of HIV related to transgender and IDUs and MSM. Those guidelines are there. We refer to those guidelines and we build upon them. But these guidelines that we're talking about here are specifically focused around sexual and reproductive health and rights. But there are many other guidance out there, and we try to pull together the relevant recommendations related to women living with HIV. Thank you.
Does anyone else have anything else that they would like to contribute from the panel?
Pascal here.
Go ahead, Pascal.
So it's a general comment that goes back to a point that Alice had made earlier. I think one of the things that has been really exciting about the development of this particular consolidated guideline is the introduction of the broader grassroots voice into the WHO process, and I think it's something that that we need to continue to ride on through the implementation process, as well, as I had mentioned before. So I think Alice, you had mentioned that there was a group, Cecilia and her group were working on research within the area, and what would be really nice is to ensure that the process now thinks about the implementation as part of the development of the guidelines, that it becomes a seamless thing, and that we also have some way of bringing together this information that is being generated at the grassroots level within the grey literature and so on, so that we can, where it's possible, inject the level of rigor that is required to bring it into a global discussion to help to extend the benefit to women all around the world.
Thank you so much, Pascal. I completely agree, and and one of the reasons we are holding these series of webinars for all the regions, actually all WHO regions. This is one of the first ones. It's really to not only disseminate and share the fact that this guideline has now come out and the process that we followed, but really to ensure that we continue to engage with the communities of women living with HIV for the implementation. And I think that, you know, we are really thinking about what could be the most useful at national and regional level. And it was what I said in my earlier presentation, is that I'm really looking forward to getting feedback from the participants on this panel and any of your colleagues on what you think would be the most useful and what are some of the challenges that you think in implementing this guideline. And we will develop tools based on those feedback. We are already thinking of developing several infographics, for instance, around the C-section issue related not only for women living with HIV, but also for healthcare providers, and around the abortion recommendation, and for some, and Avni mentioned for the safe disclosure module that we are doing for healthcare providers, dealing with safer disclosure of HIV status. So several tools are being thought of and being drafted, but will be finalized only after feedback from regions, from countries, on what would be the most useful implementation. Thank you.
Excellent.
Oh, sorry, could I just add to that quickly, Catherine? Absolutely. Have we got time? Yes. So thank you, Pascal and Angela, for those two comments. I think another really key issue here is, as we were saying, the peer review process is unfortunately one which means that a lot of the grey literature, where work which is done by grassroots women's organizations doesn't actually appear, because grassroots women's organizations and NGOs in general don't tend to write for or conduct research in a way which can appear in peer-reviewed journal articles. So I think that this is another huge area which we really need to be thinking about addressing, how to strengthen and expand the evidence base. And in fact, we have been doing some work with UNAIDS on this, which is called the ALIVE framework, which speaks so much to these issues. How can we really ensure that research which is being done is really speaking to the questions which women themselves find pertinent in our own lives, which is just what Anandi was talking about also. So I think this is a huge, exciting opportunity now, really, for us to galvanize, moving forward, galvanize ways in which the research which happens on the ground in different countries and regions, which is obviously so important, is really one which includes and engages with women living with HIV as equal partners in defining the right questions to be asked and getting the right answers which are meaningful to women, to make these guidelines real for women and effective for women. And if they're effective for women, then they're effective for all of us, and it's a win-win situation for us all.
Very, very well said, Alice. And I think a great note to end on with Manjula's comments about next steps for tools and making this a useful, implementable guideline, and also just the importance of including the people that the guideline is intended for. So with that, I want to thank all of the participants for your insightful questions and valuable feedback and comments. Please join me in thanking the panelists, IBP, and other stakeholders that made today's webinar possible. We will be sharing the recording of the webinar with everyone, and also posting it on the HRP's YouTube channel, Media HRP, and the address is there on the screen. We welcome further thoughts on dissemination and implementation of the guideline, and you can send these directly to Manjula and Narasimhan. Thank you, everyone, and have a great day.
Thanks very much. Thank you, everyone.
Thank you.